Good afternoon. I welcome all the participants and the speakers today. We are conducting this webinar in Mimar Medical College, Talegaon. Yesterday was the first session conducted successfully, and the talks were given by four highly qualified speakers. And today we are going to continue session 2. The title of webinar is Horizon, the Path Ahead. And this webinar is for young upcoming orthopedic surgeons, which will be dealt with a panel of experts in different fields. This is about the scope of various avenues in orthopedic practice. So there are four speakers today who will be talking on different topics. The first speaker is Dr.Sampat Dumbre patil. He'll be talking on care in foot and ankle surgeries. The second talk will be given by Dr.Anand Kavi on prospects in endoscopic spine surgery. The third talk will be by Dr.Abhijit Wahegaokar. He'll be talking on Intricacies in hand and microvascular surgery. The fourth talk will be given by Dr.Sameer Desai. The topic will be being a pediatric orthopedic surgeon. So these are the topics which are going to be covered today by different speakers. And I welcome again to everybody, all the participants and the speakers on this platform. And now I request our Executive Director, Dr. Nagare Madam, to address.
Very good afternoon, everyone. On behalf of Mimar Medical College, I welcome all the speakers of today. Yesterday was a very good session as briefed by all the department faculty. I think Dr. Sampat Dumbre patil could not be part of the session of yesterday, so today he is there with us. So I welcome Dr. Sampat. I could not see Dr. Anand on screen really. If Anand, if you are there, if you can just switch on your camera. Anand was with Mimar Medical College long years ago, and now he is a very good spine surgeon with a great practice in Pune city. And the other speakers are Dr. Abhijit, Wahegaokar, and Dr. Sameer. So on behalf of all the members of Mimar Medical College, all the faculty, I welcome all the speakers for today's session. Yesterday, I think more than 50 new young orthopedic surgeons attended this workshop just to get the clarity upon which way they should go ahead and which path they should choose, and is hand is a better option for me or spine is a better option for me. I think after all the four sessions, I'm very sure that all the surgeons of orthopedic field will definitely be able to screen out that what is the best for their future, and I'm sure that they'll do wonderful job during these COVID times. Whatever work we all are doing, I think COVID has just taught us that the specialty doesn't matter, because when we all served the COVID patient, we were very sure that all our basic degrees of MBBS are the foundation of our field, and every one of us can serve the humanity when it comes to the emergency situation. So I thank all of you for doing great jobs wherever you are. And once again, I welcome all the panelists and all the participants who are joining us today. Thank you very much.
Very good afternoon to all. I would like to thank our Executive Director, Dr. Sujitra Nagare Madam, for being an unwavering pillar of support in all our educational endeavors. And now we would like to start with our session. The first speaker for today will be Dr. Sampat Dumbre patil, Dr. Sampat Dumbre Patil is a renowned foot and ankle surgeon practicing in Pune. He is the director of Department of Orthopedics at Sahyadri Super Speciality Hospital in Hadapsar. Also, he is the ex-president of the Indian Foot and Ankle Society. He is the ex-council member of AO Trauma in India. Also, the ex-member of Indian Orthopedic Association and also the Maharashtra Orthopedic Association. He has published numerous journals, papers, and has been an associate editor of the BMC Musculoskeletal Journal. We are indeed happy to have you with us today, sir. And I would like to invite Dr. Sampat Dumbre Patil to continue his talk. Thank you, sir.
Yeah. So I'm going to talk about some career opportunities in foot and ankle subspecialty. As we are aware in our practice, commonly we deal with trauma, but in pertaining to foot and ankle subspecialty, we are interested in sports injuries, of course, bone as well as soft tissues, some infections, tumors, diabetic foot deformities, rheumatoid foot reconstruction, and flat foot or bunion reconstruction. I will just go through some cases like this, which are obviously road traffic accident, some ghastly looking injuries where we do reconstruct and that yields quite good results. Some soft tissue injuries like Achilles ruptures, which have been detected late, chronic injuries where we use some tendons for reconstruction and that also yields good results. Some neglected congenital deformities like this, and on reconstruction they give they are with rewarding clinical outcomes. Such severe deformity neglected till adulthood, even they can be corrected and we can give them plantigrade foot. Neuropathic feet, such ugly looking ulcers, all-smelling ulcers, patient may come to us for amputation, but even they can be reconstructed nicely. This is a neuropathic foot, again charco foot, where we have our role in reconstruction of neuropathic foot. This aspect is little less dealt with, and if we have interest in this subspecialty, this can be reconstructed to yield a good outcome. This is absolutely dislocated foot on TTC fusion, yields very significant outcome and plantigrade foot. So a lot of diabetic feet and charco foot reconstruction is rewarding, and we need to know the principles of reconstruction of diabetic foot. It is not only about ulcers or ugly looking wounds or false swelling wounds, but it is also about the charco foot reconstruction one should be aware. Sports injuries are quite common now with pro kabaddi or IPL, things are going around. Very often we see sports injuries, and typical are stress fractures, tendon injuries, ligament injuries, or something like shin splints. Nowadays, a lot of people, they undertake running as a major sports, and they land up in shin splints. Stress fractures and stress fracture common sites are known, but even stress fractures of enteric of calcaneum and cuboid are common. Flat feet is an issue with children as well as adults, and flat foot, how do we evaluate, how do we reconstruct? It's again rewarding thing. Orthotics is little less explored, and one has to have knowledge about orthotics and prosthetic. Some typical foot and ankle conditions where we can have evaluation of bunion, that is hallux valgus, cons, callosities, or as we discussed, diabetic foot care. One thing in India where we can do our work is rheumatoid foot reconstruction, and such grotesque deformities can be corrected. Here we have corrected one side to give a good result. A simple correction, and it yields very satisfactory clinical outcome. Again, orthotic care, prosthetics and orthotics is a department where we have to give inputs and and these orthotics maximum help us to manage the patient conservatively. Now, we know the broad clinical spectrum of foot and ankle conditions. Where do we get the training from? There are a lot of foreign fellowships available, and as an Indian Foot and Ankle Society member, I will encourage our young colleagues to come forward and go for these fellowships. Indian Foot and Ankle Society is very active academically, and we will help you to go for these fellowships. On our website, the information is available about these fellowships. Now, this is Glasgow Fellowship in UK, where you will get even stipend of the registrar there. Here, another fellowship in UK, Wales. It's University of Texas. Dr. Vinod Panjmavi sir is the professor there, and he has a lot of interest in charco foot reconstruction. University of Alabama, USA, where Dr. Ashish Shah sir is there. He is happy to help you in academics as well. Everywhere there is a research opportunity along with plenty of clinical work. Now, this is King's Hospital, London, Heidelberg, Germany, where Professor Hajo Thurman is there. He does a lot of endoscopic work. Even Achilles reconstruction, he does it endoscopic. In Duke, Dr. Selim Parikh sir is kind enough to offer us fellowship, which is obviously observer fellowship here. Here you won't get hands-on. Singapore, there is a fellowship in University Hospital. Chicago, USA, there is a fellowship opportunity. And of course, IFS Parikh, that is Indo Parikh Foundation is there where they offer the fellowship. Now, this is Alabama Fellowship, which we talked about. There are some Indian centers as well. This is a center in Delhi where Dr. Kamal Burija, Dr. Balvinder Rana, Dr. Maninder Singh Shah and Abhishek Jain, they collectively give you people a fellowship opportunity. Dr. Raju Shah sir, who is one of the pioneer of foot and ankle surgery in India, he has his fellowship with him at Baroda for 1 or 2 weeks. And even I'm happy to give you fellowship for a couple of weeks in Pune. Now, this is about training or foot and ankle training in subspecialty abroad or in India. Now, when we choose to practice in India, now suppose we are in some rural area, you can think of tumors, infection, or diabetic foot. In at rural part, we have a lot of fungal or which have to be dealt by routine orthopedic surgeons. In other areas, if you are thinking, you have a lot of scope about treating sports injuries, trauma, and of course, charco foot or rheumatoid foot reconstruction, along with flat section or some disease like bunion. So, my friends, so foot and ankle subspecialty is very interesting. Trauma around ankle is very common, and I will urge you young people, you should obtain a knowledge about foot and ankle pathologies, how to treat them. I may not suggest that you should practice only foot and ankle, but along with other subspecialties, foot and ankle is an interesting subspecialty. Thank you so much.
Thank you for the lecture, sir. If the audience have any questions, please, sir would like to take them now.
Sampat sir, good afternoon.
Good afternoon, Swapnil sir. How are you?
Here. Yeah, fine. I have come in the Pune after MS. I have seen you doing first elbow surgery, but after few years you are doing foot and ankle. Can you tell me what's the reason, so that our PG aspirants will know what is great in foot and ankle surgery and the treatment of foot and ankle surgery?
Yeah, that is a good question. Good question, because I have done orthopedic, general orthopedic for a long time, And I have chosen this subspecialty because there is a lot of scope for neglected things. This is a field where there are no many people interested in, but trauma is common, deformity are common, then diabetic foot is a common issue. So particularly I am practicing in rural area like Urli Kanchan, where there are a lot of foot and ankle issues, and I'm attached to corporate hospitals here in Pune, where there are a lot of sports injuries. So it's a balanced part for me where I can attend both the pathologies of neglected as well as fresh trauma. So, and really nobody was there in offering their services in foot and ankle. That's why I dedicated myself to foot and ankle.
That's very good, sir, because I've already, like, I often get advice from you for any foot and ankle problems and very valuable suggestions also. And that helps our patients in memory in past also. So that's very good, and you're doing very wonderful job. Thank you, sir.
Thank you, sir. Thank you. It's my pleasure. And I will be happy to help any of your young colleagues to send for any kind of fellowship through Indian Foot and Ankle Society. Thank you, sir.
Sir, good afternoon, sir. One question, sir. Sir, regarding talus fractures and calcaneum fractures, in complicated talus fractures, and what is the scope and what is the future outcome of the patient?
Actually, talus fractures are not common. Maybe
Yes.
general orthopedic surgeon will see at maybe once or twice a year. So it's a
Yes.
difficult scenario, but clinical outcome is not as bad as what we were thinking. Since now principles of treatments have evolved, I think we can do a good job. Although AVN arthritis, there are issues, but we can manage them well. So outcome is quite good now. Although we should keep it in mind, AVM and arthritis, they are issues, but still clinical outcome is not fusion all the time.
Thank you for taking a wonderful session, sir, and enlightening us about the nuances in ankle and foot surgery. We are indeed grateful to you for having delivered this talk. I would like to move ahead to the next session. For the next session, we have with us Dr. Anand Kavi. Dr. Anand Kavi is an established endoscopic spine surgeon currently practicing in Pune. He is going to explain about the practices and the nuances of spine surgery and endoscopic spine surgery in today's era. I hand over the mic to Dr. Anand Kavi, sir.
Thank you very much, Sriram. Are you able to hear me?
Yes, sir, we are able to hear you, sir.
Okay. At the outset, I would like to congratulate all of you for organizing this wonderful session. I think it's a very good idea that right from our residency days, if we get proper guidance and we get to know different streams of orthopedics, we can select better and utilize this opportunity in a better way in the future. So thank you very much for inviting me for this talk and wonderful meeting. Yeah, I'm extremely sorry, Shriram, that you had asked me about the introduction, and because of the time constraints, I was not able to share with you. So in short, I would like to introduce myself. I am a orthopedic surgeon practicing spine surgery and now exclusively focusing on endoscopic spine surgery. I've done MS in orthopedics with a gold medal, and I've done MRCS from Royal College of Edinburgh. Then I've done various fellowships like microvascular surgery, limb reconstructive surgery, deformity correction from UK, and then finally fellowships in endospine surgery from Taikyo University, Japan, from Inuyama University in Japan, and from South Korea. I've done nearly 47 workshops for endoscopic spine surgery as a faculty in last operating surgeon and live surgery faculty in Turkey, Japan, South Korea, Malaysia, Philippines, Egypt, and Indonesia. There is a saying that a picture speaks 1,000 words and a video speaks 1,000 pictures. So I would just like to show you a small video. So this is a small video regarding a 48-year-old gentleman having a severe extruded herniation at L5-S1 level. And this is the picture how he was before surgery, with excruciating pain, and even sitting, standing, or walking a few steps was very difficult for him. So this is the scan showing the extruded herniation at L5-S1, and this is the axial view. And these are the C-arm pictures. So this is a transforaminal endoscopic surgery. And whatever we are looking at the screen now is through a 7 mm or 8 mm incision, less than a centimeter. And then such a big herniation can be very easily removed. So this is after the removal of the herniation. And this is the free exiting route. And this is the chunk of the herniation, almost 5-6 centimeters big blob. And this is immediate after surgery. The patient is completely pain-free and symptom-free. So this is possible because transforaminal endoscopy is done under local anesthesia, and it's an awake and aware surgery. So basically, transforaminal surgery is one of the parts of the endoscopic spine surgery. So I hope you have seen the video. So it is just a demonstration about what endoscopic spine surgery is. Now the topic given to me is the prospects of endoscopic spine surgery for newcomers, for the residents, or the newly passed people. So is it merely the glamour, or is it the prospects of making money, or is it fascination that one should select endoscopic spine surgery? I would say no, it is not that. If you want to do endoscopic spine surgery, there should be passion and desire to learn. And then you should understand the philosophy, and as well as understand the deficiencies of this system. So how does it start? So most of the people say that endoscopic spine surgery has a very steep learning curve, and usually proficiency in the traditional surgery does not automatically translate into the endoscopic skills. So basically, you should know how to learn. You have to learn through methods, and there is no learning through failures, which we used to say in surgery in general context. There is no scope for failures in endoscopy. So one has to learn the pre-art, the theory, the decision making, the case selection, the technique, instruments, what is the endpoint of surgery, then what is the recovery in these cases, what are the complications. So everything has to be learned first of all. Now coming to endoscopic spine surgery proper. So what are the challenges as compared to the routine orthopedic surgery or routine spine surgery? The field of vision is very limited here, and there is very poor tactile feedback during the surgery. Another thing is surgery is performed at a depth, so it is not surface surgery. Then the anatomy is very less familiar. Secondly, the 3D orientation of the whole system is not there as we see in an open surgery. And finally, the entry is very difficult as we have to enter many a times in the axilla of the roots, or Cambine's triangle as we say in lumbar spine. So it is a difficult entry. So one has to learn all these things slowly after you practice your initial spine surgery skills. So how to go about this? So initially, one should, after completing your MS or DNB or whatever your residency period, you should go and join some spine unit and be there for a year or so and learn the regular open spine surgery, the complications, the different indications which are tackled. Have a good surgical hand in that, and then you can proceed to endoscopic spine surgery. Now, once you start doing a specialty fellowship or training, it starts with inquiry with your peer group or your seniors. And usually about the endoscopic spine surgery. Now, this is about my journey, how I started few years back. And it was very discouraging because most of the people would say it is experimental. Uh, the very well trained senior stalwarts of this spine surgery used to tell me that minimally invasive surgery is minimally effective and it has limited indications. It is good in experts' hands only. So there are discouraging comments which you come across. But if you have passion to learn, you should contact the right person. You should get in touch with the teachers, and then only you can proceed with this. Secondly, to decide about the prospects of endoscopic spine surgery, you need to assess, do you have enough time for workshops, observerships, doing fellowships? Do you have enough money or planning for money to buy the costly equipment? Because this is a completely different system. This needs costly endoscopes, high-speed bursts, radio fixer frequency cautery. So the equipment is costly. And then you should be ready to put in effort to set up this practice. And finally, then you decide on reward. Will it enhance my practice? And what are my limitations? Like, will I be focusing exclusively on endoscopic spine surgery, or I would be practicing as a general orthopedic surgeon, and this would be an added practice avenue that one should decide and then proceed with this surgery. So about the training, one should start with attending the workshops, the cadaver conferences. You should listen to the expert talks. Uh, because I feel just attending the conferences does not help you and does not yeah, make you effective learning. Because most of the times in conferences, after seeing the superhuman capabilities on the screen by celebrity speakers, I feel one gets discouraged rather than he gets encouraged in taking up the specialty. So it is always good to attend workshops or cadaver workshops where you have one-to-one training. After that, you come to the assessment stage, because endoscopic spine surgery is a very new branch. So there are many people who are already middle-aged, and even at the age of 40, 50, they try to come in and start learn this. So one should have the assessment of their age, their skill, dexterity, and one should stop procrastination and self-doubting, and then your learning starts. Then you should have search for the right teacher and training. So basically, as I've already said, first of all, you should learn the conventional spine surgery, work in a spine unit for a year or half, and then you should go in for a proper training in India, in our country, with some good teacher. Be with him for a few months, 2 years, and then you should think of going abroad for foreign fellowships. Then comes the literature. So you should always read the relevant literature, read the technique papers. Don't just read the textbooks or the technique books. So you should learn through various articles which have been published in peer-reviewed journals, and then try to understand the philosophy and know the complications, and then go step by step. Now, coming to the target, now it is not just to learn the operation, but you should also learn about the clinical assessment, then pinpointing the pathology. Because see, many a times in degenerative spinal diseases, you come across people in the age group of 70, 75, and they have multiple comorbidities and even multiple pathologies in the spinal column. So you should be able to pinpoint which level or which pathology is giving rise to symptoms, and you should be able to target that. Then you should be able to decide whether there is need for surgery and what is the right time for intervention. So all these clinical skills you can learn only by experience and working with some experienced teacher. Next challenge in learning endoscopic spine surgery is about understanding the images. So we usually see the MRI films, we usually see the X-ray pictures, but you should try to see all these images are in 2 dimension. So slowly you should try to imagine the 3-dimensional anatomy of the spine and try to interpolate this knowledge on the patient's body. So once you are through with all these steps, uh, then you can start on your own practice, slowly proceeding with the lumbar spine surgery with the initial indications like uh, simple disc herniations, soft disc herniations, and then going slowly advancing towards the complex surgeries like multi-level stenosis or instabilities or even fusion surgeries. Talking about the advancements in uh, this field is a little new, but the pace of advancements is very high. Uh, it all nearly started somewhere around 1999 or 2000. And initially it was like a simple arthroscope was introduced in the intervertebral foramen to see and just inspect the anatomy. But in last 20 years, it has made a phenomenal progress. And now the endoscopic spine surgery is divided into several aspects. It is a uniportal surgery. Then there is biportal surgery, just like you do arthroscopy. You can use one port for endoscope and other port for your working instrument. Then you can do target complex multi-level disease. Then you can do complex surgeries, even medically unfit patients, which are otherwise poor indications for general anesthesia. Then there are recent advancements wherein we can use computer-aided navigation systems for endoscopic spine surgery. Robotics is coming in a big way, not just for putting pedicular screws, but even nowadays you can apply robotics in proper endoscopic spine surgery, where the robotic arms would do your work and the operating surgeon would be in the console room, and from there he can manipulate the robotic arms. Then there are artificial intelligence based systems which are coming in, wherein when you put in the endoscope and the image is seen on the screen, the artificial intelligence itself would start guiding you towards the different anatomical aspects in what you see. So this is advancing very fast, and definitely it has a great potential, because you see world over the population is aging. Though we say that India is a young country, our average population is in the age group of 30-35, but within 15-20 years this whole group of population is start going to age, and right from the age of 50 to 75 you come across lots of degenerative spine pathologies which can be very well targeted through endoscopic spine surgery. So basically, there is immense number of patients. There are thousands and thousands of patients who require these skills and these surgeries. So I would definitely like to appeal to all of you, especially the residents, the students, already passed out doctors, to take up endoscopic spine surgery and take it as your full-fledged profession, not as an added virtue. So with that, I would complete the talk, and I would like to take some questions if you have any.
Hello, good afternoon, sir.
Yeah, good afternoon, friend.
Yes. So how much time will be required, and how many years of experience, and how much skill is required to develop endoscopic spine surgery?
Yes, Ameya,
How
this
much
question,
skill? Yes,
yeah,
sir.
this question has a very tricky answer. Like, if you already have gone through all the papers, learned the anatomy, and you have a little bit of exposure in your conventional open spine surgery, like laminotomies, laminectomies, flavectomies, instrumentation, fixation, then it is matter of few days. Like if you are a already passed out MCH neurosurgeon or an MS spine surgeon, then it is only a matter of few days. But somebody who is at a residency level, I would advise them to, right from this phase itself, you start learning about the spine, uh, put in more hours and try to get more experience through different surgeons, try to visit different spine surgeons, and at least do 6 months to 1 year basic surgical training in spine department. And then you come over to learn the endoscopic spine surgery. And then the period of learning is very short. You can take up the basic endoscopic spine surgery within a month's time. Yeah, I see one more question, sir. Are there any limited number of indications for endoscopic spine surgery? Gaurav, that's a very nice question. Yes, initially, as the system was evolving, this was only meant for, this was like a pain procedure. This was meant only for contained herniations, soft disc herniations, only herniations at L4, L5 or L3, L4. But that is only about transforaminal endoscopic spine surgery. And now over last 10 years, this has evolved, and practically all indications of degenerative spinal diseases can be very well tackled through endoscopic spine surgery. And nowadays, even the cystic lesions, some intradural tumors, or infections, spot spine, even those things can be very well tackled by endoscopic spine surgery. So the traditional limitations of this surgery, which were there 10 years back, are no more there. So practically all regular spine indications in a orthopedic practice can be very well tackled and very well done with endoscopic spine surgery.
Thank you, sir, for the interesting talk. Dr. Anand Kavi sir has indeed made it clear that spinal surgery, endoscopic spine surgery is a select field and needs lots of dedication from our side. And also we need to clear our basics in conventional spine surgery before going in this field. I thank sir for this interesting talk. We would like to move ahead to our next session. There has been a slight change in schedule. Dr. Sameer Desai will be taking the pediatric orthopedic session before Dr. Abhijit Wahegaokar. So I would like to introduce Dr. Sameer Desai. Dr. Sameer Desai is a pediatric orthopedic surgeon practicing in Pune. He has been trained in Wadia Children's Hospital, Mumbai, and has done multiple fellowships abroad, especially in Australia, Korea, and the United Kingdom. He currently specializes in clubfoot, cerebral palsy, joint infections, and pediatric hip cases. I'd like to hand over the mic to Dr. Sameer Desai to continue his lecture. Thank you, sir.
Yeah, thank you. Hello, everyone, and thanks to Orthopedic Department at Mymar Medical College for organizing this unique session. So let us look at my journey in pediatric orthopedics. This is not the ideal way, but this is just as a guideline for some of the budding residents who want to do super specialty practice. So I did my MS, DNB, DORT, MRCS, and then what is the most important thing I feel is having a good PG teacher. So I was very lucky that Dr. Ashok Johri, who is a famous pediatric orthopedic surgeon in Bombay, he was my PG teacher and he guided me during my PG days, and he gave me a topic of recurrent clubfoot. So I was in JJ hospital and we could hardly see any case of recurrent clubfoot. So I used to visit other hospitals, I used to visit other centers just to get the number of cases for my thesis. So that helped me in introducing myself to other pediatric orthopedic surgeons who were in Mumbai. I did my specialist training in Wadia. Then what I did was that I went to each center which is known for that work. For example, I went to Royal Children's Hospital, Melbourne, where I studied cerebral palsy. I went to Korea, where they do a lot of work in Ilizaro and in limb lengthening. Then I went to Australia. Then I went to United Kingdom, where they do about specialist training in PFFDs. So then I went to Vellore for a month, where they do a lot of rush rodding. So you have to go to various centers to get the training, because each center has got a specialty. What is another important thing is staying updated. You must attend conferences, you must read journals, you must read books, because that is very important. Short-term trainings do help you, because if you want to learn art, then you need short-term training. Another important thing that I would also suggest all residents is that they must go, after they have done a fellowship and started private practice, every 3 to 5 years, they must go to a new center and try to see what work they are doing. This will improve their knowledge, and also they will realize what mistakes they are doing during their surgeries. You must present papers. I have made it a point to present at least one paper in all Pune Orthopedic Society meetings. And don't be disheartened. For me to win my first prize, it took me 9 years of continuous case presentation every year. And 3 years ago, I won the best paper award. So be persistent, try to present papers, try to collect data, keep data. So whenever I do a case, I do the pre-op, I take their phone number, I try to call them up, ensure that I've got post-operative photographs. And of course, giving lectures and conferences is also important. So what is the ideal method to start specialty training? I would advise all residents that after they finish orthopedics, they must work in general orthopedics for at least 6 months to 1 year. This is because they've read just before or during their exam. And then once they start doing general orthopedics for about a year, they realize their mistakes, and then they also, the surgical hand goes on improving. So don't enter super specialty training immediately after your MS or DNB. So I would always advise that you should work in your parent institute after your MS or DNB, because your teachers know you, so they will allow you to do complex cases. Then of course work in your parent country. You are an Indian, work in India because you have got the registration and because you know the people, so you can do more and more cases. Working abroad. So a lot of students are in a rush to go abroad and train, but don't be in a hurry to go abroad. First, at least work in India for 2 to 3 years. Remember that if you are going to call yourself as a specialist, you must work in that specialty for minimum period of 2 years. So work in your specialty for 2 years and then plan to go abroad. Try to get a clinical fellowship. Don't go initially as an observer. Because if you have a clinical fellowship, then you can scrub up and you will learn more. You cannot learn from outside. You must scrub up. And then when you are involved in the discussions, you will also go back and read. Once you have got the basic training in super specialty work, then you can do short-term observer post. For example, I do pediatric hips. So I wanted to learn a little bit about adolescent hip management. So I did a 1-month fellowship in UK. So always it is important to have a mentor. So I am fortunate to have a lot of good mentors in Mumbai, in Pune. So whenever I have a doubt, I call them. Whenever they are organizing a conference, they will call me as a faculty. Whenever I am organizing a conference, I will call them as a faculty. If you have some difficult cases, you can always call them to help you. So having a mentor is very important. So why should you choose pediatric orthopedics as your specialty? If you see, this is a chart given by the government of India, and you can see that all 20.3% of disabilities are in movement. So that is the incidence, and you know that India is a young country. The number of deliveries that are happening every day, every year. So the number of pediatric cases are a lot. So let us look at the spectrum of cases that we treat right from bone legs, knock knees, toe walking, cerebral palsy, scissoring, dislocation of hips, elbow deformities, joint fingers, extra toes, pediatric spine, pediatric sports medicine. So now a lot of children are doing sports. So pediatric sports injuries are also increasing. So I'll tell you another a story when we go ahead. So a little bit about fellowship opportunities. You go to POSI website, Pediatric Orthopedic Society of India, and you'll get those accredited fellowships from POSI. There the fellowships are in Lucknow, Delhi, Bangalore, and Pune. There are many other centers also. You'll get all the information on the POSI website. In India, you can also work with private doctors in Mumbai, Pune, Jaipur, and other major centers. For example, I too have started my own fellowship about 3 years ago. So I have also trained few fellows. So like this, you can go to a private doctor also abroad. So the countries which have good pediatric orthopedic fellowships are US, UK, and Australia, but exams are compulsory. So you should be mentally prepared to give PLAB. You should be mentally prepared to give USMLE. So in pediatric orthopedics, you can, once you have done basic pediatric orthopedics, you can also work as a super specialist. So you can say, okay, I do only pediatric spine. That means scoliosis, infections. You can say that I do only pediatric sports. So I was in UK. There was one surgeon who was doing only pediatric sports. So he used to do only pediatric ACLs, pediatric PCLs, MCL reconstruction. Okay. So pediatric hip, that is young hips and adolescent hips. Now a lot of children need arthroscopic CAM, pincer lesions, EAOs. So this is another thing that you can learn. Limb deformity and deficiency, a little bit about Elizaro, how to manage limb deficiencies, deformities. So this is another super specialty work that you can work. There are few surgeons abroad who do only CP. So they'll not do any other work in pediatric orthopedics. So that is the level of super specialty that has developed abroad. And of course, rare diseases. And pediatric foot if you want, like club foot and other diseases. So what are the advantages of being a super specialist? So of course, it is the need of the hour. So if you want to practice in a metro, you must be a specialist. Patients are also searching for specialists. I visit so many doctors, so many hospitals. A lot of patients tell me, sir, we are looking for pediatric orthopedic surgeon. They're looking for a spine surgeon. They're looking for a joint replacement surgeon. So now patients also know that there are specialists. So there are specialist pediatric orthopedic surgeons. There are specialist joint replacement surgeons. So you will be invited for lecturers a little early in your career because you are a super specialist. Other surgeons will also call you for difficult cases. As a pediatric orthopedic surgeon, 80% of our work is cold orthopedics. So there is no emergency. So you need not get up at 12 o'clock at night and go and do some case except if there is a neurovascular injury in a child. And India has a huge young population. So the number of pediatric cases and the congenital anomalies are a lot. But there are also disadvantages, you see. So there is a lag period. So once you start a practice, this is a referral branch. So some time is needed for others to start referring, for a pediatrician to refer to you, a physiotherapist to refer to you, orthopedic surgeon, because he wants to see your work first. So there will always be some lag period. Then, as I mentioned, because it's a referral branch, you must keep in contact with other specialties, other doctors, because the saying is out of sight, out of mind. So if you don't keep in contact, they will stop referring you cases. Another disadvantage of pediatric orthopedics is that you need to travel a lot. So as a pediatric orthopedic surgeon, we are traveling to a lot of other cities. So, and there are many other doctors who even travel abroad just to do cases. Another thing that I have seen in my practice is that if it's a simple Colles fracture, so if I admit the child and admit an adult patient for Colles fracture, the other consultants may be a little unhappy. They may say, Sameer, you are a pediatric orthopedic surgeon. Why are you doing adult work? So sometimes an adult orthopedic surgeon may do pediatric work, but as a pediatric orthopedic surgeon, I am not allowed to do other adult work. So that is one of the disadvantages. So whether one should be attached to a teaching institute or a private practice, I feel that a mix is very important. Don't get attached only to a teaching institute. But let us look at the advantages of a teaching institute. If you are attached to a teaching institute, yes, I love teaching. I love to teach students. I am attached to 3 or 4 hospitals where we get students. So I love teaching. So it's a bonus point for me. So I get to see rare cases. So that is another advantage of a teaching hospital. Because it is a referral center, a lot of rare cases will be referred to your center. You can perform cases by different methods. So suppose if I get a child with radius ulna fracture, today I may decide to just give a cast, see the results. So I may do plating, see the results. I may do nailing, see the results. So that is another advantage of if you are in a teaching institute. You can learn and practice new techniques. I can tell you that I have learned only 20% of my work in a fellowship and 80% of my work doing actual practice and after entering clinical practice. So if you want to do new things, if you want to practice new things, you can always do it in a teaching institute. A teaching institute will always help you to arrange conferences. So this will help you in your practice so that people will refer cases to you. Okay, and of course, you can treat poor patients as they have got a very good social network. So that is another important thing. So but you don't get paid a lot in a teaching institute. So as I mentioned, it is good to have a mix, combining teaching institute, base practice and private practice. Okay. Okay, thank you.
Thank you, sir, for the interesting lecture. Sir has indeed clarified that pediatric orthopedic surgery is a specialized field and we need a lot of experience with general orthopedics before going into the field. And also he has highlighted that India is a young country and so there is increased scope for the field in the coming days. We are indeed indebted to have sir on our panel today. I would like to move on to our next speaker. Our next speaker will be Dr. Abhijit Wahegaokar, who is one of the pioneers of hand and microvascular surgery in Pune. He is an adjunct professor of hand surgery, a distinguished clinical tutor of orthopedic surgery. He is also the director of upper limb, hand and microsurgery fellowship programs and currently the consultant and head Department of Upper Extremity, Hand and Microvascular Reconstructive Surgery at Sancheti Hospital, Pune. He has published numerous publications and has almost 12 textbook chapters authored by him. He is also a visiting professor for the international faculty at Shahid Beheshti University in Tehran and the founding president of the Wrist Society of India. We are indeed lucky to have you today on our panel, sir. I would like to invite Dr. Abhijit Wahegaokar to start his lecture and hand over the mic to him. Thank you.
Thank you very much, Srirang, for that kind introduction. And at the very outset, I would like to thank the leadership of MIMER and the orthopedic department for such a wonderful initiative. And as I was listening to all the talks, and when I got the invitation to be a part, am I audible?
Sir, you are quite audible, sir.
Yeah. So when I got this introduction, when I got this invitation to this webinar, and I was just thinking to myself, what a fantastic opportunity this is. And I really wish that we had such an opportunity when we were residents so that we could get career guidance and not have to, fumble our through our career and finding direction in our lives. So without further ado, I would like to embark upon my task today, and which is about a career in hand surgery. So before I begin, I would like to share with you this fantastic aphorism by Ronnie Oldham. And whenever we are thinking about our careers, whenever we're thinking about our work, in every endeavor of life, I would rather be in pursuit of excellence rather than be in pursuit of perfection. And then what is excellence? And excellence is a result of caring more than others think is wise, risking more than others think is safe, dreaming more than others think is practical, and expecting more than others think is possible. So from this aphorism, I'm sure you must have gathered that my talk is going to be a little bit more philosophical, because much of the practical aspects about fellowship programs and about doing a fellowship have already been touched upon by the previous speakers, and very elaborately so. So indulge me as I go through this talk with you guys over the next few minutes. And again, I would like to congratulate the graduating class who have been successful in their exams and now are colleagues and orthopedic surgeons. So you're moved on from being residents to being our colleagues, and are now will be established orthopedic surgeons pretty soon in whichever place you choose to work at, and whichever institution or your private practice that you choose to be associated with. And those who haven't and are watching this webinar, I just want to say that there is light at the end of the tunnel, and it's just that it's a matter of time before you join the league of this exceptional breed of surgeons called orthopedic surgeons. This is who I am. My name is Abhijit Wahegaokar, and I am very privileged at this present moment to be serving as the founding president of the Wrist Society of India. I am also serving as the chairman of the IT committee and one of the founding executive board members of the Asia Pacific Wrist Association. I am a member of the International Relations Committee of the American Society for Surgery of the Hand. It is my distinct privilege to serve as the secretary of the Pune Orthopedic Society, an EC member of the MOA. I'm also serving as the chairman of the fellowship committee of the MOA. So anyone who is interested in applying for a fellowship through the MOA must first be a member of the MOA, and then they can apply for a fellowship program. This is a funded fellowship program, just so that you know. I am an invited member, and it's a very distinguished honor, of the French Hand Society and the International Wrist Investigators Workshop. I serve as a reviewer for the Journal of Hand Surgery American, as well as the Indian Journal of Plastic Surgery. And I am the section editor for the newly founded Journal of Arthroscopic Surgery and Sports Medicine. And one of the highlights of my career, and this is with all humility and without any pride or prejudice, I was awarded the Musculoskeletal Transplant Foundation grant. This was a grant for $100,000 for my research on acellular or decellularized nerve grafts and brachial plexus injury. And I'm very proud to say that I was the first Indian, and this is an honor for all of us, I believe, to have received this grant. So with that behind me, I want to say that this didn't come overnight, right? I'm sure all of you will appreciate that every journey, a journey of 1,000 miles, begins with a single step. And my interest with hand surgery started in September 2000, when after graduating in 1999, I had joined Bharati Vidyapit Medical College as a lecturer. And I had the privilege of joining the Bandurwala Leprosy Hospital as an honorary orthopedic surgeon. And I was pretty much assigned to doing lower limb surgery, management of wounds and infections, and amputation surgery and tendon transfers for the lower limb. And it was around this time in 2000 that the management of the hospital, which was the Pune District Leprosy Committee, was dissolved for some reason, and the government had to take over the administration. And at this time, the senior hand surgeon retired, and I was asked to do hand surgery, and I had no experience. So they gave me a few books, and they gave me a few videos, and they asked me to start doing tendon transfers for the claw hand, for decompressing the ulnar nerve. And trust me, I was so scared, and I was with trepidation, I embarked upon doing whatever hand surgery I was, with reference to that hand surgery is something that could not be dealt with just by reading, and we better have some training. And I would like to share this wonderful phrase by Mahatma Gandhi, that leprosy work is not merely medical relief. It is transforming frustration of life into joy of dedication and personal ambition into selfless service. And it was here that I realized the importance of the human touch. the people who were affected by Hansen's were stigmata of the society, and they were not even being touched by their own family members. And it was here that I pledged to devote my time to the cause of reconstructive hand surgery, especially for people suffering from leprosy. And I was so fascinated by the art of hand surgery. There were so many intricacies, the biomechanics of the tendon transfer, the anatomy of the hand. And trust me, when I was a first year student, I did not even know the anatomy of the hand. I did not know those carpal bones, pretty much like everyone. And even in residency, I was scared of the hand. And like everyone, I used to put it off as, something for reserved reading or something that I would rather omit than commit my time to. But my fate had it that I would be doing hand surgery as my career option. So the moral of the story here I'm saying is that I think you should pursue a fellowship program when you find your calling, when you have found your passion for a particular subspecialty. And this comes only by spending time in that field. It is not by what I am telling you, what my other peers have told you, what your teachers tell you, what your parents tell you. So I think you need to follow your heart. You need to listen to your heart, that voice inside you, and then follow what interests you, what impassionates you, and take it further as a lifetime work. So I started performing tendon transfers, and trust me, my first teachers were actually patients who were suffering from leprosy and were employed by the hospital. So they were physiotherapists, orthotists, OT assistants, and fantastic people. People who were missing a couple of fingers on one hand or the other. I have never found better teachers and assistants at those people, and my gratitude to date goes out, and my heart reaches out to a lot of these people. Unfortunately, some of them are no longer alive, but I will always remember till my very last breath. So with that brief introduction to how I started off with hand surgery and my journey, I would like to take you through a journey about the marvel of creation that the human hand is. And look at this particular book. There are so many books that have been written about the hand, not only about the anatomy and physiology and the biomechanics and surgery, but also about the philosophical aspect of the hand. So this wonderful book is available on Amazon. And I recommend, even if you're not willing to take up a career in hand surgery, to read this book. So this is a book by Frank Wilson, and it is entitled The Hand, How Its Use Shapes the Brain, Language, and Human Culture. Beautiful, beautiful book. I own it, I've read it, and I very highly recommend it to you. And then the evolution of the human hand is such that the opposable thumb and the DRUJ, the mere ability to bring our thumb in opposition in front of the fingers, and the DRUJ, which has evolved over a period of time, these have enhanced prehension with an unparalleled ability to execute almost anything that you can imagine. This can be done by getting strength, skill, dexterity, precision, and this has put us on top of the food chain, if you will. So it is a fantastic evolution. And this particular slide shows you the schematic diagrams of how a baboon's or a chimpanzee's hand and a man's hand has evolved. You can see that the length of the thumb has increased. The ability to oppose and thereby have different types of grips has also led us to where we are today. And I'm sure almost everyone who's listening and seeing this, watching this webinar, will identify with this very famous painting by Leonardo da Vinci. And this is the human hand and the God's hand. But I would say that more practical would be this particular picture, where we have evolved from the ape's hand to the human hand. And the human hand, like I mentioned before, is not only a part of your profession or your ability to do activities of daily living, but also a very inseparable part of art and culture. You can do these beautiful sculptures and micro work with your hands, and anything and almost everything that your brain can conceptualize, can imagine, you have the ability to execute it, to carry it out with your hands. Look at this particular slide. We as orthopedic surgeons who have very strong arms and hands can do all these procedures, such as reduction of a dislocated hip joint with sheer strength, hammering and nailing, and at the same hands can also give you the precision of a microsurgeon and the dexterity and the ability to repair vessels and nerves which are smaller than 0.5 millimeters in diameter. So how important are your hands? And before we go to that, I'm sure you must have heard of this very famous philosopher, Immanuel Kant, and a very beautiful and a very poignant phrase: the hand is a visible part of the brain. And it's so true if you really think about it. So the hand is one of the most complex parts of our body, and there is such an intricate interplay between the tendons, the tissues, the bones, the nerves, and they allow us for performing everything that we desire to do, different professions, different métiers, as we say. And without our hands, it would be impossible to do even simple routine tasks that we so much take for granted. And it is our hands that make us skilled and valuable workers. However, not only are hands so important, because we use them in everyday activities, our hands are the most prone to injury. And 1 out of 3 patients in your emergency room will suffer from a hand injury. And I'm sure you guys must have experienced this through your residency program. So what is hand surgery? Hand surgery is a field of medicine that deals with problems of the hand, the wrist, and the forearm. And hand surgeons are specially trained to take care of these problems and operate when necessary for any problem related to these particular areas. However, many hand surgeons are also surgeons who have trained in shoulder and elbow problems, and these are people who call themselves upper limb surgeons or upper extremity surgeons. And worldwide, hand surgeons have either an orthopedic or a plastic background, and in some countries they also have a general surgery background, and then they go on to have additional training in surgery of the hand. There are countries like Sweden where they have a 5-year hand surgery residency program after your basic medical graduation. So they have really evolved to a level where hand surgery is deemed as an end discipline, pretty much like we have for a lot of disciplines even in our country. So hand surgeons basically are people who are trained to deal with, this is a busy slide, but you can just go through it. And you can see that this is, although not an exhaustive coverage of the indications, but there is so much that you can do with your training in hand surgery, right from microvascular reconstruction to arthroscopy, congenital hand surgery, peripheral nerve surgery, tetraplegia, tendon transfers, rheumatoid. The list just goes on and on and on. And this is one particular field where you have to apply your, not only your knowledge, but your imagination. And it is your imagination that will be the limiting factor in deciding what is it that you can reconstruct, even about after very severe either congenital deformities or traumatic deformities. And you can serve as a bridge or a colleague to almost every subspecialty and discipline in your institute. For example, you have an arthroplasty surgeon who has had an infection. You can do in a joint replacement surgery. You can do a vascularized bone transfer, for that matter. You can cover soft tissue defects that have been compromised by infection. You can be a good colleague to your pediatric orthopedic surgeon. Like I collaborate, I'm very privileged to collaborate with Dr. Sameer Desai in dealing with congenital hand anomalies and also obstetrical brachial plexus palsy. So it's so much that you can do. Look at this slide for that matter. And you can see that there is an amputation of the thumb. This is right hand. He was a carpenter, and while working, he amputated his thumb as well as his index finger and his middle finger. And this would have been such a debilitating problem for his hand had this not been replanted, or if we were not able to put it back together. So microvascular surgery gives you the ability to put these back together. A crushed finger was advised amputation, and we were able to reconstruct it with a local flap and a fixator. This was an infected wound, chronic presentation with a debridement and a flap to save the finger. This is again soft tissue damage. You can see that the extensor tendon is completely gone here. That is a bone and which is devoid of periosteum. So we do something called as a reverse cross finger flap to cover up that defect. Look at this, very distal amputations, but to that patient, this is important because he's a music player and he needs those fingers. So we were able to replant his index finger even at that level of amputation. So microvascular skills can be very, very helpful. This may appear to be a very grotesque injury. This was a crush injury. You can see that you can almost not make out what tissue is what. And this was again something which was very bad, and he was advised amputation at some other hospital. And this is another perspective of the same injury. However, we were able to reconstruct this and restore function in his hand with different techniques and using your imagination for that matter. 11-year-old girl with an amputation of the arm right through the elbow. This is something that no one should have, leave apart a small child who is 11 years of age, who has the entire life in front of her. So this was a laborer's child, and you could imagine that this was something that her father could not pay for, but we did it free of charge at a medical college. This was at Bharati Vidyapit Medical College at that point in time, and this was an elevator door injury, and we were able to put this arm back on again, thereby we were able to save the hand. What about congenital anomalies? Trust me that there is no surgery which is as rewarding as a smile on a child's hand. A child born without a thumb, and this is something called as policization. So we use the index finger, and then we perform a set of these intricate steps to create a thumb out of the index finger, and the child is able to grasp again. To give an opposable digit changes the function and the ability to perform daily activities. So is it only microvascular surgery? You will be surprised to know that only about 20% of trained hand surgeons continue to do microsurgery in their clinical practice. So let not all of these previous slides and images deter you from taking up hand surgery. If you are not interested in hand surgery, that is not the end of the world. There is so much more you can do utilizing the skills of an orthopedic surgeon and still continue your career in hand surgery. So one of the most important and the most exciting horizons that we have in hand surgery is small joint arthroscopy. And we are now doing scopies of the wrist, the CMC joint, the MP, the PIP joint as well. Endoscopies, we are doing, you have already heard about foot and ankle, we're doing elbow and shoulder as well. Here is a video of the wrist, the scapholunate ligament in perspective, and you can do your repairs and reconstructions. And trust me that this is something which is advancing and is evolving by leaps and bounds. You can do these TFCC repairs, ligament repairs, distal radius fracture reductions and fixations, scaphoid fractures and non-unions. The list is endless. And like I said, it is only your imagination that is going to stop you from or allow you to carry out surgeries and procedures that you wish to. Elbow arthroscopy, again, it's very sad that very few and very limited people, even in the United States, it's surprising that only 11% of people do elbow arthroscopy. So this is again something that might interest the newer generation and take up elbow arthroscopy. Imagine a young person who has a flail limb. It is so depressing. The suicide tendency in people with brachial plexus injury is almost 40%. It is unbelievable. It's incredible. A young person who has had a motorcycle or a motor vehicle accident wants to end his life because people are not offering him solutions. So we can do not only primary nerve repairs, but we can reanimate even in chronic injuries. So this is the gracilis muscle, which is harvested on its neurovascular bundle, and then you can see that a flail limb can become a more meaningful function. So this is the gracilis muscle, and the flail, completely flail limb, this muscle transfer can enable that patient to perform bimanual activities. A lot of people ask me, what is this function good for? But for a person who has nothing, a little is a lot. This was an aphorism by Sterling Bunnell, who was one of the founders and the fathers of hand surgery. Another patient who had primary nerve repair, his right limb was paralyzed, and you can see, although it is a limited function, even this function is enough. This guy had zero abduction, zero flexion of the hand from a partial brachial plexus injury, and he's able to go back to his vocation to kind of do whatever he wants. And like I said, the horizons of hand surgery are ever expanding. And we have now moved on to hand transplantation. I'm sure you must have heard about the recent bilateral hand transplant in Mumbai, which was done by a very dear friend of mine, Dr. Nilesh Sadhbhai. One of my own patients had undergone a bilateral hand transplant, a young girl of about 25 years of age, bilateral above elbow amputee. No kind of prosthesis will give her the prehension, the sensation, and she underwent a successful hand transplant, and she is back to her education and back to using her hands 3 years after the hand transplant. So in summary, from replantation to revascularization to reconstruction and transplantation, from head to the toe, from adults to children, from skin to bone, a hand surgeon is equipped, trained, and capable of dealing with any problem that would come his way. So with that brief introduction to what hand surgery is all about, what are the training opportunities that are available? So usually post-residency, people take up either a 1 or 2 year fellowship program, and these are usually orthopedic or plastic surgeons, but you may want to train even more than that if that so interests you. And in India, we have an established FNB program, which is of 2 years duration, and you could look it up on the website to understand the details of this particular program. We have an MCH in hand surgery, which is offered by the Christian Medical College in Vellore. And then there are fellowship programs. So if you do not want, or if you're not fortunate enough, or you don't want to study for these entrance exams, or you don't qualify for it for whatever reason, you may want to apply for fellowship programs. And these are programs which are offered either by institutions or by peers or individuals. There may be industry-funded fellowship programs, and they may be recognized or unrecognized, like the FNB program. So feel free to reach out to any one of your seniors, your peers, and we'll be more than happy to help you through this uncharted territory. There are overseas fellowship programs also. In the United States, almost all of the hand surgery programs now are ACGME accredited. Therefore, you will have to sit your USMLE exams and then apply for it. However, as we speak today, the orthopedic residency and the fellowship programs have become extremely difficult and very coveted, especially hand surgery programs. And therefore, it may not be an easy cakewalk. What you could do is maybe you could complete a hand surgery fellowship program in India and then go for observership to people of eminence so that you continuously keep on sharpening your sword. Be committed to a lifetime of learning. A fellowship program is not a one-year program, but a continued and a very sustained learning and teaching endeavor. So you may want to try to go to Europe at different centers. Asia, for that matter, is one of the most sought of destinations because there may be paid fellowship programs, and visa and travel may not be as difficult as it is for the United States and in Europe. So in hand surgery also, there are subspecialties. There are people who are doing only pediatric hand surgery. There are people who are doing only brachial plexus and peripheral nerve surgery, rheumatoid hand surgery, arthroscopy, and sports medicine. There are people who are doing only microvascular reconstructive surgery, trauma of the hands, and so on, and wrist surgery. It is extremely exciting how over a few years, a subspecialty like hand surgery has evolved to subspecialty training. And this is a very nice paper. It is an open access paper on PubMed. I would like you to please read this paper. And this will give you a lot of insight. Look at this particular chart. Subspecialty training is the highest in orthopedic resident subset. Almost 87 to 90% of orthopedic trainees will pursue a fellowship training program and then commit themselves to a subspecialty kind of a career. This is another kind of slide to show that hand surgery only ranks second. But again, mind you, this was in 2014. As we speak today, I think hand surgery is one of the most coveted subspecialty programs in the United States. So having said all of that, what are the determinants for you to take up any subspecialty, leave apart hand? When I was interviewing for my fellowship, Professor Harold Kleinert, and he was 84 years of age at that time, God bless his soul, he is no more. He asked me, Abhijit, why do you want to be a hand surgeon? I started giving him all sorts of funny answers and vague answers, of which I was not convinced, I realized. And a person who has trained more than 1,500 residents and fellows very gently put his arm around my shoulder. And he said, Dr. W, because he could not pronounce my last name. He said, Dr. W, you should be a hand surgeon because you want to wake up every morning wanting to do hand surgery and then die doing it. That is the amount of commitment. That is the amount of dedication that these people have sworn themselves to. So find your passion. And then your determinants would be the sundry details as to what kind of a practice that you would want to be involved in, an academic or a group or an individual practice. But for me, to my mind, the single most important factor is your commitment and your passion to doing a subspecialty training and then keep on doing it. Like Sameer Desai said some time ago, if you have decided to become a pediatric orthopedic surgeon, you have spent time doing pediatric orthopedic training. Why would you like to fix a tibia in an adult, right? So please respect your subspecialty training, and therefore your colleagues and your peers will then respect your commitment and your practice will bloom. So we also have a hand surgery fellowship program at our institute. This is a one-year fellowship. We are currently booked for the next 3 years. However, if any one of you is interested in our fellowship program, please visit our website and the tab on career with the details for hand surgery fellowship. If you're interested in coming for an observership, if you need letters of recommendation, if you want to learn hand surgery, if you need any guidance other than hand surgery, we'll be more than happy to be of assistance to you. Understand that I cannot end this talk without committing and commending the two families that we are associated with. As orthopedic surgeons and as young individuals in practice, you will soon realize you will be spending more time at the hospital and at work than at in the family and in the home. Be grateful to everyone. Acknowledge their contribution to your growth and make it a symbiotic relationship. When I started off with my career in hand surgery, my kids were so small and I didn't even realize how soon they have grown, how soon they have matured into wonderful children. And my spouse has been single-handedly responsible for taking care of my family while I was away at work. And I would like to express my deep gratitude to my patients, without whom I would not have been who I am. They have placed their hands in mine with faith and trust. To my friends and colleagues who have believed in me always, who have encouraged me to follow my passion and have supported me through every walk and endeavor of life. To my teachers and mentors, and we need not say more about this, they have shaped my life and career. My teachers have taught me as a father would teach his son. And to them, I owe my gratitude and my respects. For my parents, for raising me up and instilling values in me. And of course, to my spouse and kids, for making my life worthwhile. And again, I should also mention my residents and fellows now. This was when I was a fellow. But as a teacher, my life would be meaningless without my residents and fellows. They just compel you to think. They compel you to learn. They compel you to be better today than what you were yesterday. So I owe my gratitude to my residents and fellows, without whom my work would be so meaningless. And also for patient care. These are few of my teachers. This is Professor Harold Kleinert on the top left. This is Professor Christoph Mathula, who has taught me as a father would teach a child. This is Professor Kazuteru Doi, a master in brachial plexus surgery. Professor Mathula is a pioneer of wrist arthroscopy and wrist surgery, one of the leaders in the world. Professor Harold Kleinert, who is no more unfortunately, is a person who has trained the who's who in hand surgery. Jesse Jupiter, for example, is Dr. Kleinert's student. This is Professor Christoph Oberlin, who is a giant in the field of brachial plexus surgery. This is Professor Alain Gilbert, who is a giant in congenital and pediatric hand surgery and obstetrical brachial plexus palsy. Whatever we know about obstetrical brachial plexus palsy, we owe it to this particular man. And of course, Professor Raja Sabapati from Ganga Hospital, who is the face of hand surgery in India. And with that, I would like to thank you and would end my talk with this particular phrase. In Sanskrit, it says, Nahid jnanena satrusham pavitramiha vidyate. There is nothing more purifying than knowledge. And I wish each and every one of you all the very best, a fantastic and a brilliant career ahead of you. May you all grow to be people who transform healthcare in India, and may you all be leaders in the field of your choice. And thank you very much for a patient listening. I'm open to any questions that you may have. Thank you.
Hello, sir. There are some questions in the chat.
Yeah.
So we have one question regarding that do we need few years post-MS experience exclusively in hand trauma before we apply for the hand fellowship? And what is the scope of arthroscopic hand surgeries as of today?
Yeah, great question. When we were residents and my teachers before me, I'm sure Professor Wahegaokar, Professor Mahesh Gauri sir, so people who have trained much before you guys have, they will identify, they will concede that when we were doing our residency programs, we also had to do a compulsory 6-month or a 1-year stint in the field of general surgery, neurosurgery, or plastic surgery as an alternative to orthopedic training. And this was meant to hone in and improve your basic skills. Hand surgery is an offshoot of orthopedic, general, plastic, microvascular surgery. And therefore, to my mind, after your residency program, it is too early to jump into any fellowship program. Please grow, please mature in your basic discipline, acquire the skills, spend some time. It may be very fascinating to see one of your teachers do a fantastic surgery, for example, an endoscopic spine surgery. However, if you don't have what it takes to be an endoscopic spine surgeon, or if you don't like that field, when you start seeing patients over and over again on a long-term follow-up, when you have put some work behind you, that is when you will realize and find your passions. So I would very strongly urge each and every one of you to very strongly consider having some basic trauma experience, having some basic orthopedic surgery experience, work where you will be responsible for your decisions, work at a place where you'll get to learn and enhance your skills and knowledge. And that is when, if you feel that hand surgery is your calling, go ahead and apply. Arthroscopy everywhere has a great future and a great scope, but understand that I don't consider myself as an arthroscopy surgeon or a microvascular surgeon or a pediatric hand surgeon. No, these are skills in your armamentarium to deal with a particular problem your patient presents to you with. So look at them as techniques or manners by which you will solve a health related problem for your patient. Don't endeavor to be a wrist arthroscopy surgeon without being comfortable with opening up the wrist and doing a tendon tenodesis procedure for that matter, or an open TFCC repair. So spend time learning the basic tenets of hand surgery and then move on to more advanced and more complex procedures. I hope that answers the question.
This second question, which is more practical based. So they're asking to shed some light on the practice of hand surgery and plastic surgery, and also to give guidance on the competition faced in the early years of establishing the practice.
Great question, Dr. Sumit. Is that correct? Sumit Ragute. Yeah. Is he, can I see his face? Is he online here? Is Dr. Sumit online? If not, it's okay. So Sumit, I want to share something very personal and very deep kind of a meaning to you. Competition is only with yourself, not with not with anyone else. If you endeavor to be better tomorrow than what you are today, that is the only competition that you should be concerned about. All right. And this kind of competition with your colleagues and your peers is the most unhealthy kind of competition. That is when people start having heart attacks and MIs at 35 and 40 years of age. That is when you start doing unethical things and you start putting other interests ahead of your patient's best interests. So be in competition with yourself and no one else. You're answerable only to your patients and to yourself. Trust me. Okay, I may sound like a deluded fool to you, but at 48 now, I'm very convinced of what I'm saying. 2, if you still feel society may be unfair, these are the times when you should be working as a group. So if you have like-minded people, if you have friends who are willing to collaborate and take friendship to a more rewarding lifestyle. It is so sad that we all lose touch with our friends as we get on with our lives. So you can collaborate with your friends, have a more meaningful work experience, have a more, kind of a passionate, our passion and take it forward so that we can provide the best to our patients. Because we have a team, we can take holidays. Because we are a team, we can collaborate and do surgeries. A 14-hour break plexus surgery is suddenly reduced to a 6 or an 8-hour procedure. So convert competition in a negative manner. This is what I'll say to you. I hope you see what I am trying to tell you. Do we have any other questions?
Hi, Abhijit. Swapnil, Dr. Swapnil. Hello.
So I'm sorry.
Nice to hear you.
Yeah, hi.
Dr. Swapnil.
Yes,
hi,
yes.
Abhijit.
Hi.
Yeah, very elaborative and very interesting talk. And in my residency from 2006 to 2009, there was I was a resident in Sion Hospital, which is the biggest Asia trauma center in Asia. And that period, there was like any hand surgery, directly first our resident job is to call plastic surgeon. That was our duty. But now so much intervention and so much in orthopedic also, orthopedician also involved in that. That is very great, and you have told every resident that how important is this orthopedician's role in hand surgery. It's very important. So, is there any? I just wanted to know whether you require plastic surgery in your as an assistant, or just can
Great. Yeah.
Orthopedic surgeon become a hand surgeon?
Sure. That's a fantastic question. So, and I must share with everyone who's listening that I am so fortunate to be, to have colleagues, my generation and my friends such as Dr. Swapnil Desai and all other, Dr. Mahesh Darpan Mahesh Gauri and my contemporaries are so this is a fantastic time to be working in. Everyone has chosen a discipline and they are doing full justice to it, and it makes work so interesting. And so say, for example, I have a patient who has some pelviacetabular problem. I have no hesitation in referring it to maybe Sir Dr. Swapnil Desai or anyone who does that work. I am not the person to be doing it. And with that background, I would say a hand surgeon is an orthoplastic surgeon. So a plastic surgeon has to be as much an orthopedic surgeon to be able to do hand surgery, and an orthopedic surgeon has to be as much a plastic surgeon to be able to do hand surgery. So it is a beautiful confluence of two disciplines. You cannot say that only plastic surgeons will be hand surgeons, or only orthopods will be hand or wrist surgeons. The most renowned wrist surgeon, the one who has developed a prosthesis, the only complete prosthesis for the wrist joint, for the DRUJ, is a plastic surgeon. Can you beat that? Dr. Louis Shecker, all right? Some of the finest microsurgeons in the world are orthopedic surgeons, all right? So it is not, see, where we all born orthopedic surgeons. We have learned, we have taught ourselves. Likewise, we have to just learn these skills to be able to follow that particular discipline. So hand surgery does require that you are able to do nerve surgery, that you're able to do microvascular surgery, that you're able to perform flaps, not only local flaps, but free flaps for that matter. It is just a skill. You learn that skill and you're able to do it. So yes, I think perhaps orthopedic surgeons are a little better equipped because we also talk about biomechanics. Maybe that may give you an edge, but it doesn't shouldn't stop anyone from doing what his passion is. You remember this movie, Three Idiots? And Amir Khan had a very powerful statement in that. He said, "Jahan pe bhi gyan bat raha hu, main wahan pe jaake baith jata hu." So wherever there is knowledge, wherever there is skill that you can learn, wherever there are opportunities, you guys are living in times where there are so many workshops, there are so many teaching events, there are webinars, people are willing to teach. When we were residents, we didn't have this. To go for a cadaver course was a dream. It was so expensive. There are so many cadaver courses now, so please enhance your skills. Nicholas Barton, Barton's fracture, you must have all heard of Barton's fracture, right? Nicholas Barton said, if there is any skill which has the potential for improving your patient's outcomes, it is well worth the time and effort spent in learning that skill. I need not say more.
Yes, yes. Thanks, Abhijit, for your elaborate answer. Thanks.
Thank you very much. Thanks for the opportunity.
Yeah.
It's been an honor. Thank you.
Thank you, sir, for the inspiring talk. It was beautifully highlighted, and it was not only educational, but also highlighted the philosophical aspects of the practice of hand. And it indeed goes to show that you love your subject quite a lot. And I'd like to take this opportunity to congratulate you on receiving the prestigious MTS Fellowship Grant. It is a proud moment, not only for us as orthopedicians, but also as countrymen and fellow Indians. I'd like to thank sir for delivering this inspired talk.
Thank you.
And
thank you.
This marks the conclusion of our session 2. I'd like to invite our medical superintendent, Dr. Kamath sir, to deliver the concluding remarks.
First of all, I would like to mention our collaboration with the Pune Orthopedic Society. So we are very thankful to Dr. Narayan Karne and Dr. Abhijit Wahegaokar, who are the president and secretary respectively. And what better way to show the patronage than to deliver a brilliant lecture. Thank you, Abhijit. So from yesterday, we have been getting our dose of glamour, and today we had hand and foot and endoscopic spine. But everyone is saying the same thing. Do not forget your basics before you move on to your subspecialty. And today they even talked about specialty. It was mentioned in pediatric orthopedics, and also Abhijit mentioned about some people who are doing only wrist arthroscopy. See, everything sounds so glamorous, and then the masters make it sound so simple, but there are years and years of hard work behind it, which is not visible. So do not forget that. And another thing to learn from the masters is they are so down to earth and humble. That should be inculcated. So a lot of sparks must have been ignited after all the fare which has been dished out yesterday and today. So what have we for tomorrow? Now, the first talk on orthopedic oncology by Dr. Yogesh Panchavag. This is one field which has relatively fewer takers than the other glamorous subspecialties. But all the people cannot be accommodated in glamour and hi-fi things. So some people have to remain in ground realities. So we have corporate hospitals and arthroplasty by Dr. Abhijit Agashe. And then of course, there are the two in which most of the people will have to go. One is academic institutions by Dr. Sanjay Dev and government health services by Dr. Anil Santapure. Do not forget that you cannot be totally dependent on private practice. Something like Corona comes along and you may have to shut down your practice for a few days. Then you need to be attached to some teaching institution if you want to survive. So see you tomorrow. Thank you, everyone. Bye.